Welcome to iCare Cancer Research Link. I am Dr. Folakemi Odedino, your scientific host for this exciting program, and the program provides a direct link to prostate cancer research discoveries. As you are aware, the primary reason we have this show is to be able to address the prostate cancer disparities experienced by Black men globally, and for us to be able to provide life-changing scientific discoveries, especially those with implications for primary and secondary preventive interventions, as well as provide you the information that would enhance access to prostate cancer clinical trials. In line with this approach, the iCare Cancer Research Link episodes focus on scientific discoveries that has impact for Black men's health. I am bringing back one of the people who have been a guest on our show today. I'm bringing back Dr. Kim Babel Johnson. Welcome, Dr. Babel Johnson.
It's a pleasure to be back.
Yes. Uh, Here we are again. I told you that we are going to bring you back, that you have a lot to share
I'm
with us, right?
I'm always excited to be here, and
Okay.
this has been one of my favorite platforms in which to participate. So thank you for the open invitation.
Okay, great, great, great. So, first of all, let me just first of all start with what we usually start with. I know you've introduced yourself to us before, but can we have an introduction again just for this episode?
Absolutely. I'll try to make it briefer. But I am Dr. Kim Barbell Johnson. I am a trained family physician, trained at Mayo Clinic almost 3 decades ago in family medicine and practiced family medicine most of my career. And I'm now the director for Community Clinical Trials Administration at the Mayo Clinic Cancer Center in Florida. This allows me to really do what I've been doing for a couple decades, which are clinical trials, along with the people that do clinical trials at the Cancer Center, and to find those spaces that those clinical trials best align with our community. And then to partner with the community and community clinicians that I've worked with for 20 years to make sure that patients in our, what we call our catchment area, are able to join trials at Mayo Clinic, either on our campus in a decentralized way. So that is my professional role and responsibility. I am also a mom, so I'm the mother of two adult children, and between the three of us, we have three dogs and one cat. So
Yeah. All fun. Okay, so I feel that I need to change your initials to DCT. So maybe I'll start calling you Dr. DCT. Do you know what that means?
is that decentralized clinical trials?
Yes. That would be decentralized clinical trial. As
Oh,
we
that would be my
usually do
honor.
within a show, we like to learn a little bit about you. You can do a talent or you can share some information. I'm going to actually put you on the spot. I want you to share what surprised you the most during your first visit to Nigeria.
Oh my gosh. So I have to first say that I didn't really have any true expectations. I knew I would go to Nigeria. I was going to another conference invited by an amazing team of scientists, and I was excited to travel. The first thing that overcame me was as I was approaching the continent of Africa and I could see it out of the plane window, tears just streamed down my face. I couldn't help myself. It was hours on a plane. It wasn't tears of fatigue. It was just this innate emotional connection to just seeing the continent of Africa as a person of color and recognizing the privilege that it was to come back to where my genetic roots were, and
Mhm.
just to just have that spiritually. The first thing that was, I guess, that kind of level set that trip was, for me, it was really God's gift to me through other people for the
Mhm.
opportunity to really take me to the source of just all of the things that make me passionate about what I do. And that was to introduce me to the source of our power. The
Yes.
power and the resilience that existed in the
Mm.
communities was as present as the source of disparities. And it was
Mm,
just I was just so proud. I've never been more proud, and I'm a Caribbean person, so I love being, part of the Caribbean and West Indian community. But it was the first time that I really felt truly aligned and
mm,
empowered by brothers and sisters. And this is before I met the first person, before I even met a person. It was
mm,
just that element of surprise, and then to be there and to just be blown away by ministers of health and women scientists and men scientists and an international consortium from Mayo Clinics and John Hopkins, and just to see everyone really just seeding into the work to help us in a global way to decrease this burden in cancer
mm.
care. And that was a surprise. I guess it shouldn't have been a surprise, but everything sometimes seems so like Burger King, like I want it my way. But this was one of those places where it wasn't about my way or your way. It really was about our way. And
Yes.
I am so happy that I had that experience. I apologize for the long answer, but I
No.
cannot even put to words appropriately what that trip did for just rejuvenating
Yes.
my soul.
Yes.
So
Yes, that was very well put. And then from traveling to Nigeria, now you have a very critical role in the iCare Consortium, oversighting multiple clinical trials across the world, including in Africa. Can you share a little bit more about your role in iCare Consortium?
So I am honored this year with the iCare Consortium to serve with Dr. Colonna Otero and others to oversee translational science and clinical trials that are happening and funded and sponsored by the iCare grant. That allows me to do a very particular and specific things with a team of people who are an interdisciplinary group of experts who are familiar with clinical trials, ways that we do intervention or collect
Mhm,
information from patients, and an interdisciplinary group of international folks who are overseeing all of the trials that are happening in this space to make sure that the rules and the regulations and the ethics and the cultural competency that's required to make sure that not only we do this in the best possible way of
mhm,
science, but that
mhm,
we understand even the differences between countries when it comes to certain bodies. There may be things that we do here in the United States that it's the same process, but it's
mhm,
not the same process. So it allows me to work with a team of people who actually marry, these cultural nuances so
mhm,
that we can have a robust amount of information at the end of these trials that are
mhm,
delivered to a community of scientists and a community of patients ultimately, that they can trust that it was done with the kind of integrity that left nothing on the table. And
yeah,
so that is the role of the TRACS Core specifically to oversee the clinical trials and
mhm.
translational science operations for those trials that are under the iCare grant.
Yes. So the translational research and clinical trial services is obviously one of the most critical
Mhm.
aspect of iCare and the iCare core because you really oversight from conceptualizing all the way to implementing, all those clinical trials. So tell us a little bit more about some of the projects that your core actually supports within the iCare consortium.
Absolutely. So there are 5 full projects that are currently funded, but during the life cycle of the grant, there may be other grants and other pilot projects that are funded. So currently, what we're doing is we're providing basically scaffolding support because these trials have been written and proposals have been conceptualized independently by investigators who are passionate about this work, who have experience in clinical trials, and we're just making sure, I guess, that they're standardized. So one of the full projects is one that I'm already involved with here in the United States, and that is one of our trials that we're evaluating the administration of vitamin D in Black men who are low in vitamin D to see if we can actually identify any signals of immune signals
Yeah.
as we replace the vitamin D. That's one of the types of trials. So we're looking at Black men with metastatic or advanced cancers, those without metastatic cancers, to evaluate the administration of vitamin D. Similarly, there's another trial that's happening that is very similar to one that's happening here that actually is first in class in many ways, where we're delivering cancer care in the home at Mayo Clinic in Florida. And that trial is under this full project is uh, designed to see if we can administer cancer therapy in the home versus the clinic, and to see how specifically Black men with advanced metastatic prostate cancer respond to that. Not respond to the safety and efficacy of the treatment, because as is with the case in the United States trial,
Mhm.
we're not necessarily, or the trial that we're already doing, we're not necessarily looking at just how the treatment works based on geography. But with
Mhm.
the Black population, we don't really have a sense of how, if we decentralize trials, are
Yes.
all this, is it just a matter of geography? Is it like
Mhm.
I deliver it here, or I deliver it there, or are there other nuances that we are important to us for our comfort level, for us to receive that care? Is it important what you look like and who brings that care to the
Mhm.
home? And
Mhm.
is the home a place that the same family unit is supporting as with other cultures
Mhm.
and other populations? So that is one trial where we're specifically looking at things like the burden of travel and patient satisfaction, but we're looking specifically at Black men in that clinical trial, regulated way with prostate cancer, to see if we can get a better sense of what the potential for cost-effective treatment at home or in a decentralized way, and would that be satisfactory or preferable to that population of men. There is another trial where we're looking at what we call VIRA, or virtual
Mhm.
reality assistance. And that's a trial that you're very familiar with, Dr. Detna. And that's what we call a pragmatic trial to evaluate this VIRA, virtual reality. And that is focusing on using virtual reality. And just for the sake of those who may not know what virtual reality is, if you kind of think of, those PlayStation type games that you put a
Mhm.
mask on and you can see uh, in live and living color what's happening, but it's 3D, and it's not necessarily watching a TV, but it integrates you into that space. So in that virtual reality way, we're actually looking at whether that is a supportive tool for Black men who are diagnosed with prostate cancer. And the goal for that is to really evaluate whether the virtual reality based intervention can reduce those things that we know
Mhm.
impact Black men, or people with prostate cancer, things such as anxiety,
Mhm.
coping skills and strategies, increasing knowledge about prostate cancer. And as you can imagine, that's one of the most important things that we can do in trials
Mhm.
like this, is to get information that's not only about the care and the treatment and the genetic differences that exist, but we know that we bring our whole bodies, our whole selves, our whole lived histories into these spaces. And sometimes, and oftentimes, when you hear the diagnosis of cancer, it's a
Mhm.
very heavy diagnosis. In this case, we know from Black men who have told us, and it's well
Mhm.
documented, that when Black men hear that diagnosis, they hear very little else, because it's such
Yeah.
a heavy diagnosis, and all of the things that go through their head are not necessarily all the things that they're ready to talk about. Things like sex and sexuality and how it will impact performance. Things
Mhm.
like, will I die or will I not die? Or what will the treatment do? And so some of those things that you might think might be comfortable just having a book to read or
Mhm.
something else to deliver that information, maybe if you're in that space and we can make it more personal through virtual reality, and that's what we're going to find out in this trial. Is that a better way to deliver this intervention to Black men? And if we do, does it impact those things that we know down the road Black men experience with prostate cancer, like anxiety? And so that allows us to bring culturally sensitive information and patient education for for emotional support
Mhm.
as well. So those are the kinds of trials. We have a genomic trial, and that one is a combination of what we call genomics and metabolics, and we're
Mhm.
investigating survivorship
Yeah.
really in the ethnically diverse groups. So we have a number of just a number of trials that are all outlined. They're all different. Like I said, they are the independent and the intellectual property of the investigators who have conceptualized this true, robust scientific work that's designed by experienced scientists and those teams, and they don't necessarily need oversight. What we're
Yeah.
trying to do is make sure that A and B and C and D and E are all connected in some way, because normally when we do clinical trials we are just kind of focused and myopic and focused on just what we need to do. But in
Mhm.
this international space, we want to make sure that we get the information that is appropriately done in the appropriate way, not only for independent individual institutions,
Mhm.
but that will be translatable between institutions here in America and between countries, and even within countries and continents,
Mhm.
making sure that within even the same country that uh,
Mhm.
we're able to standardize processes so that that clinical trial is being carried out in a way that provides the best data so
Mhm.
that we can have the information that will impact patient care down the road.
Yeah, yeah, that is this is the I gave you the initial of this T. I think we need to have G in front of that, Dr. Global Decentralized Clinical Trials, right? Because
Oh, the
we
global
try
the global part is so exciting. I tell you, Dr. Detmer, one of the things that I didn't even realize, and like I said, I'm one of the co-leads, and I have a very experienced Nigerian scientists who work with me in supporting Dr. Colon Ortero. But there are simple things like how do we store things? And you conceptualize what we do, say in America, and you think about, advanced countries that have just all sorts of privileges in the scientific. And we want to make sure that we don't take anything for granted. So,
Mhm.
as we're going to have the samples that we collect, for example, shipped to one lab here at Mayo Clinic, we have
Mhm.
to think they can't do the overnight FedEx like we do to get
Yeah.
things here. And
It takes
so,
time to
how
get
does
from
that
there.
happen, right?
Yes,
How does that happen? How
yes.
do we work with those parties? Do we store it from one
Mhm.
university to another? How is that temperature control going to take
Mhm.
place? What kind of regulatory documents do we need to make sure that nothing happens and the custody of those samples stay exactly how we're expecting it to say, so that nothing changes by the time those samples get to the lab, so that we can make sure that we're evaluating A and A appropriately. So there are things that I just have been learning sitting
Yeah.
with colleagues here that we just don't think about naturally, because we get so in the habit of speaking our
Mhm.
language and doing things how we know that we're doing things.
Mhm.
And going to Nigeria really helped me to understand what that looks like
That
and
is
what that
so
feels like.
important. That is,
So
I feel that one of the things that that could easily come up as you lead this tracks call is best practices for collaborating with international sites for clinical trials, because there's been so much that I know fires that you have to put out, and there's
yeah,
been so much understanding of teaching people on our side that wait a minute, things are a little bit different on both
yeah,
sides. So you
it
can't swap what we have here to what we have. And I know I want you to talk a little bit more about the dialogue that you had in even selecting the intervention and
yeah,
making sure that that intervention is going to be an intervention that is going to be available to the
yes.
international sites and it's not going, I mean, everybody benefits. Talk to me about
Absolutely.
that.
So one of the trials that I mentioned, our prostate cancer low vitamin D trial led by Dr. Colon Otero, is going to be led in Nigeria by, again, another esteemed oncologist, Dr. Pupula and others on his team. As we've been meeting, and we meet weekly actually at 7 a.m. every Wednesday morning, we meet to talk about where we are. So that in and of
Before you
itself is.
continue, can you talk a little bit about the timing for those meetings? Because people forget that there's 6 hours difference, so
There is
everybody
a,
needs to
yeah.
sacrifice some things, right?
Yes, and so before I came on board to this trial, there were 4 o'clock in the afternoon meetings because that's when it was convenient for Mayo Clinic doctors and others here to finish their day and then do that. And there was a sensitivity that there's 6 hours, but now we're asking our colleagues, our partners, not better or we're our partners to be up at 10 o'clock at night talking about this stuff. And so that just was not the ideal situation.
Hmm.
So there's a
Yeah,
conversation, first of all, to say, what is a better time? So
yeah.
7 o'clock was chosen because number one, it's usually before we start our clinical work most of the time in all the people on the team. And independent of what you're doing, in Nigeria, which is where the study is taking place between two universities, it's a more appropriate time of the day. And so that is why the time is 7 a.m. for us, and it translates, of course, to 1 o'clock, I believe, for those who are just finishing their lunch or on a lunch break there in Nigeria. Little things like that make a difference because
They
what
do.
we do when we're sitting and, we have these incredible meetings, Dr. Detna. And so we're very, Mayo, and you have all the teachers for the laboratory and the biospecimen collection. And we bring in our protocols to say, we want to teach you how to do it our way. And then we say things like at our meeting, like, so if you pull up on your computer, can you just send us a document? Like, we want that. Like, I could do that right now because I'm sitting here with Wi-Fi enabled and not sensitive to what these incredibly busy clinicians, multitasking clinicians, one at 10 o'clock or 1 o'clock in the afternoon could potentially be doing. So, like, just the cultural competency that we often talk when we talk about these things, we're often talking about. Are we culturally appropriate for the patients, right? The patients we're taking care of. Well, in this global space, we need to make sure that we're culturally appropriate in working with each other. And so
Absolutely.
that is a lesson that even requires a couple. Let's pull back a little bit and talk about, are we talking the same language? Are we talking
Yes.
about the same paperwork? Is this appropriate time for you? Do you have Wi-Fi the same way that I have Wi-Fi to meet at this time? Is there a better time to meet? And all
Mhm.
of these things have been discussed. And I have to say, because we are working with such an incredibly l- incredibly generous group of folks who are passionate about this work in Africa. There has been no hesitation to just respond. Has it been fair? Not necessarily, because everything has been a little bit one-sided. Because I'm the funder, the Department of Defense is funding this, and we want to make sure that we're meeting those United States things. But we are getting closer to where I think as a team we are understanding that there are differences that and nuances that need to be appreciated in simply working together to integrate clinical trials. And it's not the first time that it's being done in the country, but this nuance, the nuance of working particularly with those who are, esteemed Black and Brown physicians and clinical teams, clinical research organizations that work throughout the continent with
Mhm.
maybe one point person who is able to connect with the one person at the equivalent of their FDA, but it might only be on a Thursday, like those little nuances that are
Yeah.
so important to move this along has been an incredible lesson. And
Yeah.
how to do that in a respectful way
And
has
that
been
is
an
the paper
incredible
that is
lesson.
out in the making. So I'm looking forward to you
I
working
I
with the team
I
in
I
Africa.
wish I had sat at your feet, Dr. Odetna, because with your years of consortia, a lot of these lessons if the book had been written before would have been
I know,
less.
but this one will be a great one because you literally are walking through it with the clinical trials, and I
we
think a lot of best practices. But I
and
did cut you short. You were talking about the need to make sure that the intervention is tailored to
Yes,
everybody. goes to
Yes. So something, one of the things I like about this trial is we talk about cancer care. Sometimes the intervention is therapy in a way that we think about chemotherapy, immunotherapy. But what we've recognized and other data support is that the levels of vitamin D are important. And there are things that we suspect that we will find that supports that if you replace your vitamin D levels to normal, that and those levels stay normal, that you will have a better outcome in terms of your survivorship. And that data, again, is in the making. However, something like vitamin D that we think of as just go to like a GNC, Publix, wherever we go, take it off of the shelf. We have already conceptualized from the studies that we did how many, international units of milligrams of vitamin D is effective.
Mhm,
We know how to get it. We order it at our pharmacies all of the
mhm.
time. And we know that with things that are not necessarily medications that are prescribed, that sometimes the substances in those things are as important as the active ingredient. So one
Absolutely.
of the things that the investigators on both countries are like, we want the best vitamin D that's available, right,
Mhm,
for our patients in the right dose. Ordinarily, because we are so quick to
mhm,
say, well, we have the best this, we'll just send it to you.
mhm.
And when we thought about that, you just think about, yes, that might be an easy way to do that. But first of all, there are processes for us to send something internationally that has to go through their FDA that could potentially delay or be denied, right,
Mhm,
by
mhm.
their country. So understanding that was a process in and of itself. And it was costly. It was an $8,000 difference for us to bring vitamin D into the country. But as you think about it, it's vitamin D,
Yeah.
vitamin D that our doctors in Nigeria are prescribing all the time.
Yes.
So, recognizing that there's a source of vitamin D and that we can take their vitamin D and our vitamin D and make sure our pharmacists sign off on the fact that they're
Mhm,
equivalent. And that's not only good for an 8-week trial of intervention, but you think about what we're saying. We're saying that
yeah.
vitamin D needs to be replaced. When you're finished with a source from the study, and vitamin D is beneficial to you, what vitamin D are you going to get if you live in a certain country? The vitamin D that's in your country.
Yes.
So it makes most sense for us to consider these trials and yes, find the points of intersectionality and make sure things are equivalent. But you've got to think about the community. You got to think about where are they going to get this. You got to
Mhm,
think about, if do they need to come back to the office every 2 weeks to get their supply, or
mhm,
can we give them 100 pills? Is it going to be
mhm,
stored at the right temperature? But it needs to be something that we consider. How
mhm,
do these patients who have cancer or a history of prostate cancer,
mhm,
and they're entering a study to help us to understand, and it's going to help the United States Blacks more. It probably will help a lot of others because there's
mhm,
a certain amount of this that we know from other studies that we've done in partnership with African investigators, that we are able to source information
mhm.
in this epigenetic way that is
Absolutely.
actually critical to us making, because the population of in the US of Blacks are sometimes more integrated, multicultural. So
Mhm,
understanding those things that might be significantly important to people of color, to Black men with Nigerian or African roots, it's extremely important. So the information is important. The study and the way that we carry out the study is important. But what other messages that we send and what else is important? Sustainability for the community, making sure that we have people, like I said, who look like and pharmacists who look like our patients. It's important for
mhm.
us here. It's important for us
Over
to
there.
make sure that it's there. So
Yeah.
again, you wouldn't think these are conversations that doctors with lots of PhDs and letters behind their names are talking about at 7 o'clock in the morning. But these are the very things that are important to make sure that we cover, and it may not be in a regulatory article that you currently would read, right, in the science, but they're very important. And because it's not in the science, I think what you said about making sure that we write an article to share these experiences so that no one is taking for granted the importance of these things, not only to us but to the patients that are involved.
Yeah, absolutely. Oh, and so well said. I mean, we're almost at 30 minutes. I can't believe this conversation is so critical.
You're gonna have to learn to shut me up, Dr. Adat, now.
These conversations are so critical conversations to have. But there are going to be a lot of our audiences listening to you and going, "Oh wow, there is a vitamin D prostate cancer trial going on in the United States as
Mhm.
well as in Nigeria. Can you talk about where those are so that if people want to, what is the criteria? Who is eligible for those trials? So that
Yeah.
people can, we are going to put that, we are of course going to put that on the screen
Okay.
so that people can sign in on who the contact person is if they want to enroll in the clinical trial.
Well, this trial that of which I speak, the one that has been led by Dr. Colonna, has been enrolling successfully here at Mayo Clinic in Florida. Is exciting because it's enrolling at Mayo Clinic in Florida, but we have partnered with laboratories and people around the country and phlebotomists around the country to make sure that we can do these things without a patient ever stepping onto our campus.
Mhm,
So the first criteria is being a Black man who have a history of prostate cancer. That
mhm,
is first because that's the group that we're most interested in. And then we pre-screen those men if there's a suspicion that they are low in vitamin D, and most often it's because you're not taking vitamin D or your
mhm,
doctor mentioned that you were low in vitamin D. So we if you have a history or suspicion of being low in vitamin D, and then you qualify by our laboratory cutoff to be low, which is the number that we use in the studies 30, then you then make sure that you're safe for the study and making sure that your renal function and things like calcium. So very scientific things to make sure that you're safe with the
mhm,
intervention. And then our doctor actually meets with you, but not on campus. So Dr. Cologne and Dr. Pupula meets with those who are in the study to understand their cancer journey, document the prostate cancer journey. And then once there's a sign off and the clinician actually says you're right for the study and you've done all your informed consent, then we are able to send in a remote way to deliver in the United States. We deliver it through couriers and like UPS or FedEx, and we send the medication to our patients. We need to do laboratories throughout the study, and so we partner with a group that actually is able. You're welcome to come to campus, but
mhm,
this in any state except for two in the United States, like Nebraska and somewhere else, where it's you just legally we can't do that. We are able to set up a laboratory courier to a phlebotomy company. We use Flip Finders here to go to
mhm,
your home or to a place that you're comfortable with to draw your blood, collect it, and do all the regulatory things to get it back to us. And then that sample is sent here. And then at the end of the study, again, we meet with the patients. And so this happens over a course of 8 to 10 weeks, and 8 weeks of intervention, sometimes 2 weeks to get the
mhm,
preliminary things done. But the nice thing about this is that if you are interested in being just even knowing about your vitamin D level and you're
yeah,
a Black man with prostate cancer, that you
mhm,
can actually you can sign up for this trial. And like you said, you'll put the information of how to do that on our Mayo Clinic website. We have information, and the easiest thing that I always tell patients is that we're 904-953-2000, which is the number to Mayo Clinic, and all you have to say is get me to clinical trials, and we will find who you need to talk to. But we'll get that information to this platform so that you can have it specifically, and then we will go through the requirements. You will know everything that you need to know that would happen in the space of that trial. You will understand how you will be compensated for the time that you might be participating if you qualify for this trial. And if those things are fine with you, then we will have you sign an informed consent document that says you're participating. Let's say we come out, you say you're and you qualify and everything is going right, and you sign that informed consent document, and then you decide I don't want to participate in this
mhm,
anymore, or I'm not going to be available for the next 8 weeks, or anything. The informed consent document is not a marriage. So at any
mhm,
point that you decide that you do not want to be in the trial, and we have not had that experience for any of those types of reasons in this history of this trial. So again, it's a wonderful opportunity to participate in something that could potentially help you personally, but to advance the body of information and to be empowered. Be
yes,
empowered by contributing to something. If you're a Black man with prostate cancer, and I think the evidence will be coming very shortly because Dr. Colon and the laboratory scientists that he's working with are taking chunks of data and evaluating, parts of it. So we're not waiting till the entire trial to make sure that things are going well, that we're actually able to see some changes, and that everything is going as we have predicted scientifically. So I'm excited about that, and because it is one of our very first decentralized clinical trials
Mhm.
for our academic campus. We're very proud that it's been going so well. And I'm very proud of the Black community for embracing this, because there are many naysayers who may have said, oh, Black people don't want you to come to their house, or Black people this and Black people that.
We
And
want you to come. Come do the
to tell
study.
you the truth, yes. I mean, I think it's a matter, it was a matter of choice. Like we
Yes.
have to, but before I was signing off on the company, I want you to know that even as the team of researchers, when we were told who does this around the country and
Mm.
who we could partner with, we wanted to know, who do you hire?
Yes.
What are the criteria? How do they spin the blood? What card do they take? How do they
Absolutely.
call the patient? Do they say Miss and Mr.? And then we tell them exactly what we want to do and make sure that they follow our Mayo Clinic specific processes, so that you're
Right.
not getting alternative care just because it's not on our campus. You're getting the equivocal care as if you were coming to our campus. And that is the best part of these well done studies. And just imagine that very same thing will be happening, maybe not with all of the nuances, but will be happening in Nigeria in a way that works for our global community. The advances in the space and the eye care community is really contributing in so many ways to advancing knowledge for all of us, for us in the clinical community and those in the patient community. And I'm so grateful for eye care for that.
Yeah. Now you know. Doctor GDCT for no reason. She is a global decentralized clinical trial. She's very passionate about clinical trials. Anywhere she meets anybody, she's talking about clinical trials.
Yes,
And
people
I just
run them
want to
in
put a
other
plug
direction
in
now.
there. I want to put a plug in because I'm sure Dr. Babel Johnson may have forgotten, but you did sign up to actually co-host a clinical trials iCare TV show for iCare, and that is going to start taping in March. It was a long time ago that
Okay.
you said yes to it, but
I
we
knew
are
you would keep
coming
me
right.
honest.
There's
we
nothing
had
that you say yes to that we don't have it written down somewhere. So
I am sure we pinky sweared or something, but I am more than happy to, and I would love just we have such an incredible media director in BIMS that I will just wait for the phone call and to tell me what to do and when to do it. So I'm excited
absolutely.
about that.
So it's gonna be in March. So this has really been very incredible. We are going to put out on the screen so that people can see how do I connect to be able to participate in the prostate cancer vitamin D trials, who to contact. We will also provide a contact for the Nigerian vitamin D trial as well. So you can get to know who you should contact immediately in case you meet the
Yes.
criteria that Dr. Babel Johnson discussed, and we're going to put those criteria up as well, and then you can connect. Before we
Absolutely.
wrap up, it's always really great talking to you. Thank you so much for coming back to the Cancer Research Link. Is there anything else that you would like to share before we wrap up?
I am always just so grateful for the opportunity. I'm always so excited because not everyone is doing this, making sure that we are getting information to patients and to communities. So I'm extremely excited about that. I just want to continue to remind your listening audience that there are a lot of people who look like us who are behind the scenes doing this work on our behalf. And so I know sometimes it gets a little bit disheartening, but we are empowered with by the need to do this, but we're also empowered because we have patients and participants from communities who are feeding us and cheering us on as we do it. And I think that it's an all of us kind of thing. So encourage our listeners to just consider, if not prostate cancer trials, but consider just keeping your ear open for ways that you can communicate and bring information to science. A survey, sign up for our research registries, looking at things that you can control how you participate. But I believe that we will get further if we go together than if we go alone. So thank you so much again, Dr. Detner, for all that you do and for the
That is
iCCaRE Consortia.
so very well said. And iCare is a supporter of the Cancer Research Registry. So we are going to put the information for the Community Research Registry alongside with the QR code and the website so that you can click on the QR code and you can get access and you can enroll in the Community Research Registry. So thank you so much, Dr.
You're
Babel
very
Johnson, for
welcome.
such an engaging dialogue. Thanks to our audience for joining us for the iCare Cancer Research link. As you know, the key to discovery, or part of the key to discovery, is participating in clinical trials, as has been very well explained by Dr. Babel Johnson, who is one of the directors for our track score for the iCare Consortium. And remember, the best evidence of cancer care is for us to directly link you to cancer research discovery. I am Dr. Folakemi Odedina, and it's been a pleasure to have you be part of our dialogue today. Until next time, thanks and bye.
Thank you.